Good afternoon. I'm Dr. Bill Wyatt again, and I'm a board certified member of the American Orthodontic Society and also board certified in the International Association of Orthodontics. And I've been practicing nothing but orthodontics along with some TMJ that goes with the orthodontics for the last 42 years. So I'm going to uh, start out showing you a nice case here this morning about its preventive and interceptive type of orthodontics. And I have an appliance here that is a definite force for class 2 elastics. I mean, they have to wear them or else their front teeth are going to stick out like mad, and their front teeth will hurt when they take the elastics off. So there's a force there to wear the elastics, along with several other important factors like this young man is a tongue thruster. He's also a mouth breather, and so but not a severe one. He's not in crossbite, and he's in class 2 relation with several millimeters of overbite and overjet, and some crowding apparently. And we go in and do this slicing technique, which we do these pulpotomies on him to give the teeth the space they need at the time they need it. And so it's quite an interesting case to do it right. So we have to stay in it for a fairly long time, but it's an interesting case if you're interested in doing early orthodontic treatment. This is not all that terribly early, but it's an interesting case if you're doing orthodontics, or if you're not and you have a child that's got problems like this, you might look at this video too and learn a few things about orthodontics. So here we go. Here is the young man, has a pretty good facial structure, not bad really at all. Uh, Chin's back a little bit, but he's class 2 and his teeth are sticking out about something like that. So when he get these back and his jaw's free to come out and everything, well, he'll look a good bit better. So anyway, we'll go to the next picture here. Now you can see his front teeth kind of poking through there, and he's got this kind of bulge in the upper lip where the tongue is going through and pushing those teeth out. Good looking kid though, and he needs a little help here along the way. Now when he smiles, of course you see those two big front teeth, and when he's a tongue thruster he swallows without biting, but it hasn't really messed up the vertical height of the face. It's just a little bit more than this uh, part right in here, just a little bit, but not enough to detract from the looks of it. In fact, he's a nice looking kid, isn't he? And we're gonna just not worry too much about the vertical height of the face on this case because it'll work out quite well. Now, when you look at it, he's got a space in here. If you were to watch him swallow, the tongue would stick out up into this area rather than widening out the palate, and it's widened the lower arch to some extent, but not bad yet. So we're catching this case at a good time here for help in the treatment, but we're going to be here a good time. Now these teeth are a little crowded. You'll see we're going to shave these cuspids. We're going to reduce those cuspids and do these pulpotomies on them. And you ought to learn how to do that. That's something that's very important. And you don't have to go to all extremes. I've done thousands of these things, and we never use a rubber dam. We don't go right in there, and then we pack the nerve canal with a real dense mixture of zinc oxide and eugenol. I mean, it's like amalgam when we pack it in there. You'll see it on these teeth with the x-rays later on. So that's another factor involved in here. And get these teeth lined up. They'll be a little off center because he's a little more class 2 on one side than he is the other. Okay, let's look at the right side of the mouth, and it's pretty much class 2. You know, this tooth right here ought to be, this point ought to be down in here, you know, where it kind of comes up like this, and even further back than that, with the lower molar out in front a good bit. See, but it's more class 2 than the other side, and so we'll go over and take a look. Now you can see he's got quite a overjet, and the bite's kind of open from the tongue coming in here, and he swallows and pulls back on these teeth some right in this area. He hasn't really widened the lower arch out enough. A lot of bad tongue thrusters, mouth breathers that keep their tongue down in the bottom arch all the time, the one side or both sides, or one side, or they both spread out, then they jump over to one side usually. So you'll have a unilateral crossbite. Sometimes it'll be a bilateral crossbite. You can tell just looking at the thing. Okay, now I'm going to, I think, go to the inside. Now you see he sucks the lip back when you swallow, and do not bite together properly. You try it. Most people that don't do this can't swallow without biting their teeth together. It demonstrates so much that I can do it, but when I do, I have to pull my lip back, so you activate the lip. A normal swallow has no activation of the lip, but an infantile swallow pattern, or a pattern that you swallow with, if you or a tongue thruster, you do activate the lip. And it doesn't matter, you can be 50 years old and still swallow wrong. You see, I had a physician that we had to break him of that habit, you see. All right, it's in one of the videos if you want to go back through and see them. We got a lot of these videos, and it's interesting. Now we're going to bring this back and this forward some, and bring this together, and we're going to do it with what we call a Mitchell appliance. I named it excuse me, after Dr. Dave Mitchell, who was head of the department at Atlanta at Emory, and he and I taught together for several years. He was a smart guy, you know. Okay. All right, here we go. On the left side of the mouth, he's just end to end, but actually this bottom tooth should be out like that. So it's a halfway class 2 to start with also. Okay, now look at the upper. You can see it's kind of elongated in here, and we get through with this, it'll be wider back here and more rounded out and brought in from the front. You can look at the shape. I'll show you the models. You can compare the first model, this is when we first took them, and then where we were when we quit. Now these teeth they're pulled back in some, and that crowds them up more, and the tongue kind of sliding over the top of these. So we're going to go in and put some little fingers, we call them fingers. There's some metal, an 030 wire, spot welded on the band and then soldered over that, and then bent to fit right up in the palate and catch the tongue and stop it from coming through there. And then you need to get the airway going, because if you stop the tongue thrust, you need to have an open airway really for the child. All right, let's go to the next one. Now here we are into the treatment quite a ways, and I'm going to stop this just for a minute. I'm going to pause. Okay, we are into the treatment a good bit now, and all the upper anterior teeth are lined up. And when you get them lined up, you can put this Mitchell appliance in the mouth, and you rig it up. That's a rectangular appliance fitting in those 4 anterior teeth, and then it comes up over the cuspid and goes back to the molar, and you put a hook on it in here where you're going to put elastic. You see this hook going down right here, and you're going to wear elastic off of that. You see the hook right over here. So the elastic, well, the elastic is on it right now as far as that goes. Now you have a spring. Well, I'll explain that when we get over here and look straight at it. Now as we go back, these teeth come down some. See, so our bite is closed down some, so we'll have to put some reverse curve in some of these to keep the bite at the right level. Okay, now this will show you the elastic force right here. Now what you do when you hook this thing up, you measure what force a certain size elastic has on it. Let's say if this pulls with 10 ounces of force here, you got 10 ounces of force here, then we put spring pressure in here. We take our Dontrix gauge, loosen this, and go back until this has 8 ounces. In other words, it's 2 ounces less than the elastic. So your elastic has 2 ounces more force than this spring in here. Now when you activate this spring, I'm not going in detail on this because you can go back to this Mitchell appliance video and it'll go into real detail. But I tell you, you leave this rubber band off, you've got 10, you'll have 8 ounces of force over here, and whatever the force on the other side, maybe it'll be the same. So that 16 ounces of force would be on these 4 anterior teeth up here. And those 4 anterior teeth will begin to feel uncomfortable even when you take the elastic off to eat lunch. And I've had kids that wouldn't wear these things. You put this on, they said, well, I took them off to eat and they hurt, you know. So they put them back on again. And this thing makes people wear their elastics. It's more efficient than this fancy deal, you know, you glue on here and up to the cuspid, you know, because it doesn't make them wear them. It's just convenient and nice, a little appliance to go in there. But this actually doesn't force them to put it on, but it makes it very uncomfortable to leave it off. And if they don't wear it, these teeth will just go out like mad, see. So you can tell that. So it's a very efficient class 2 corrector. So in this little video, we've done the slicing technique. We've got the fingers on the lower anterior teeth, the break the tongue thrust. We're going to widen out this upper arch to give him a little more airway. There's a whole lot going on in this case. It doesn't meet the eye at first. And so a lot of young people into orthodontics don't think of all these different things. So you need to go back and review these videos. We do the best we can to let everybody know what needs to be done. And then if you get in there and you do a lot of widening, you've got to put some buccal root torque on these teeth to keep them flat, you see, and go back so that the roots go out, and that's where it helps the airway a lot when you expand the palate. Okay, the other side, very similar thing, and this wire is up above the cusp. It doesn't touch anything else till it gets back to the molar, you see. And this about, say, 10 ounces or 8 ounces here. Then you have to have 2 ounces more on the rubber band. So you measure the rubber band's force and then loosen this lock nut and push it back till it has, so this spring force in here is 2 ounces, it's not very good, 2, less than this elastic. So there's always 2 ounces over here and 2 ounces on this side, where you got 4 ounces of force. It's actually pushing the maxilla back and bringing the mandible forward with your class 2 elastics. I drop the hook so that this little rectangle in here will be as low as we can get it, and that helps so it drops it less. Now you may have to put some bends in these wires to keep it staying up, so you want to end up here with the teeth that are good overbite and overjet up in underneath here. Okay, let's go on. I don't want to take all day running through this, because there's a lot of people just want to watch for a few minutes. Now there's still a bunch of baby teeth in here, see? These are all deciduous teeth from here back, or deciduous teeth. Now we are correcting this problem and lining it back and got good torque on these teeth now, and back inside looking quite good. But sometimes in these 2-phase and the long-acting cases, we stayed with this case right on through. If it took a little longer just waiting on the teeth to erupt in the mouth. All right, here are the tongue thrust devices. It's an that's an 030 wire, spot welded on a band. You fit the bands and then you take them out and spot weld these wires, and then you'll have a band hitting on a tooth here with this, well, let's say the band, and you look at them sideways, and the wire will be sticking up here, and then you spot weld it there, and then you flow solder over that wire. So you gotta really tear it to get this thing off of there. I don't want them swallowing them if they break them off, and you keep your bands bonded to the wire, or tied to the wire strong, so it's hard for them to lose this. And brother, these are effective in stopping tongue thrust. Now some people want them sharp, and some people want more, so I put them from the top on 2 in there. Somebody's persistent and still doing this. All right, here's the permanent molar, and this is deciduous, and we've done the slicing on these cuspids, and you will see this on the x-ray. We don't just pussyfoot around it, and when we put that zinc oxide and eugenol in, I pack it in there with an amalgam packer, and I've never had one of them blow up. but I had an old surgeon do some for a person, and they had never done this before. That is kind of smeared a soft mix of zinc oxide and eugenol in there, and it leaked, and the teeth swelled. It had some problem with them. It still worked, but it shouldn't have been. They should have packed it in there. We're going to do this second phase on this later on, and we'll save enough for the second bicuspid right in here. Then we'll get the first bi here and the cuspid here. We'll have plenty of room to come in. Okay. I don't know where these videos are going to go and who's going to be looking at them. I'm sure that wherever they are, there'll be a lot of people that never do these pulpotomies, but doing those is a neat thing. You just give the space. And if you want to go on my website, I've got that article that I published years ago on how to do this, and it's good, and it really works. I've taken a lot of people and straightened their teeth up by just guiding the deciduous teeth into the mouth and getting them functioning correctly with doing no orthodontics other than the reduction of these teeth and the second deciduous molars in there, and brought their teeth in. My son was one of them, and you can look at it, and it's something that works. But it's you got to deaden them and do a lot of pulpotomy work and stuff, and some of the orthodontics, they're training them and they don't have them deaden anything. That's a big mistake. They ought to be doing that, and this is a preventive and interceptive thing that I am trying to get the pediatric dentist to be doing this type of orthodontics. I've looked in, there was almost no preventive and interceptive stuff going on when I first started this. I started doing orthodontics back in when I first got out. I kind of grew up in an orthodontic family and knew some about it when I went into dental school. Okay, now we look there, the little finger there, and there we are again with the elastic. And brother, this guy doesn't want to take this off. He takes it off 30 minutes, these teeth will be hurting him. So he puts the elastic back on here, and the elastics, you got to change them. I like every day or two anyway, to keep the pressure up, because this spring stays pretty much the same. And if it's pressing with 8 ounces of force, 8 ounces, and you've got only 10 on this, then this will get weak. And if the spring ever overpowers the elastic, in other words, it continues to be 8 and the elastic goes down to 7, then you will have force on these teeth, and you want the elastic to be more than the spring, but just about 2 ounces more. Okay, there it is on the other side. All right, let's flip on through here pretty quick. Now we're going to come back in and do this reduction of the deciduous second molar, and we still haven't done that, but we've got this back now, just virtually in a class 1 relation. See, the upper and lower teeth now fit together right there. We pull the lowers forward and these backward, and we've got him hitting in a super class 1 relation. Now, this thing really forces people in a sense to wear the elastic, or if they don't, boy, you know about it, and they know about it, and their parents know it. When they come in, you know they haven't been wearing the blooming thing. Because if you wear it, it's going to take your teeth back and bring your lowers forward. It just works. I don't care who you are. If you wear those elastics in there, it's going to change the thing. See, it doesn't make a difference who you are. You can be 90 years old and it would do it also. So anyway, there we are back at that point. It's 4 of 87, looks like, and we got him in a kind of a super class 1 relation. You take it off, it'll slip back forward a little bit. Now you look, we had these were on bands and they were a little bit high, so we dropped the arch wire and put these brackets down lower so it wouldn't be chewing on them, and that doesn't make a difference as long as you got the occlusal surface going along correctly. Alright, there it is, 4 of 87, and the kid looks quite good now. You remember when he came back, this was full up here? Well, it's looking normal now. And if we go back and look at the side, the chin is out more in relation to the upper arch, and the facial structure looks good. We haven't increased the vertical any that I can tell from here. You could measure it on yourself if you want to, but the kid looks good, and that's what I go by. Are we making the face more beautiful or more at ease? Now when he smiles, you can see his full teeth, and you can see this is open. That's a poor picture. This was made before digital photography, and I had to take what I got. The midline's off to the side. This side is more class 2. See, and this one is less, and it's kind of off in the midline here, so we'll try to get that lined up. Another, of course, there'll be a whole series of the lights, the bad on the teeth. Now here we're still going in here, I think, on the bottom now. Oh yeah, we have done the pulpotomy on this deciduous molar right here. See, I wanted to save enough space right in here for this bicuspid, and I wanted to get my cuspid and my first bi in, and then wait, and I'd have enough room for this second bi to come in. So you go in and trim down and do the pulpotomy down here with a round burr, and you'll see how to do that on these videos on this slicing. And now I'll put these teeth in their correct positions by doing that reduction. And we have literally done thousands of these during my lifetime. And honest to God, I have never had one of them blow up, because they've all been good teeth. You know, I don't do this on a abscess tooth. I just don't do it on them. You can't. You got to do a real genuine root canal if you do that. These, you just go in and ream the pulp out, and while they're bleeding, we pack that zinc oxide eugenol in there, and I've never had one of them blow up. Now, I spoke one time in Boston, had professors from 3 different universities there in their pediatric department, and every one of them wanted to mix something else in the zinc oxide and eugenol. I said, well, all right, y'all just go ahead if you must, but you don't have to, because I've done so many of them that way. This stuff, the hard mix of zinc oxide and eugenol and packed it in there like amalgam, and I've never had one of them blow up. And it's still in there when the tooth comes out too. You don't have to fill over it either. So here the overjet and overbite and all that's looking good. And we've got places here for the cuspids and the bicuspid. Now we've got room enough from here. We go through here up to the lateral, and we got room for this cuspid to come up in here and this bicuspid to come up in there. And watch that go. And you can go look back on this slicing technique. There's a video on that, and I've got my own son, the one that's grown now, and you can see how bad he was to start, and I never touched him with orthodontic appliances. And see what his mouth looks like. Okay, this is the upper had a little more space. We didn't have to do all that reduction up there, and the teeth came in good. And down here on the bottom, you can see where we came down. You just leave both roots in there, but you cut this off at a kind of an angle, and this bicuspid comes up, and the crown kind of fits in this area right there and kind of drops back into this space, and then you'll have a little more space. But this second bicuspid has ample room to come in here, and this first one will come in good, and the cuspid will come in. You watch that as we go. So there's the overjet, and you can see how much he had, and this parts this lip pursed out like that. Now when we get this back in here, this will come forward some. This is lined up good, and there he is. Now with this, we've got this out a little far, but it's going to come back on its own. And you see we have taken this back, and you see where this molar is in relationship to the upper second molar. You see that's in there, and it comes in good. Now this is poor Panorex, but you can, this is before we started that thing, but we've got him back now in a good class 1 relationship. This is 986, and here we are with that appliance in. You see we got that spring between, got a little space open between these here. Normally this goes back, and these teeth just go right along with it, but this thing is back now, and this is lined up, and we open the bite, and there are the fingers. Now look at where we did this pulpotomy. You see that pulpotomy on that cuspid tooth? When that cuspid comes out, that'll still be there, so you do not have to put some kind of filling over your zinc oxide eugenol. It'll stay in there several years. I've had it stay in there and come out, and it'll break off. The tip of this may break off as this tooth erupts up into it and eats the root away, and there'll be nothing but the zinc oxide eugenol, and this tooth will just butt into it. It'll break it off, and it'll come out, and you'll have a little piece of that zinc oxide eugenol in the socket. When you take it out, it'll come out with it. All right, here's a young man at 11 of 90. Look what a neat facial profile he's got now. I don't care what your self shows. He's a good-looking kid, and he's got a good facial height. And personally, after you do this for a long time, you get to where you can look at somebody and see. It may be an artistic thing, but you get to where you know, and you know what you want more than you'll be able to get what you want in doing it. But I don't have to go back and take a selfie of that kid to see that it's good, and it is good. And he looks good. When he looks from the front, he looks good. And the other side, he looks good. And a good smile line and everything. Now, he's got some stain on these teeth. I don't think we had anything to do with that, but we may have. I don't know how it happened. Something like he's got some decalcification up here, or he didn't brush that properly. Maybe some of that I should have stayed on him a little harder, keeping him brushing good. But his teeth look good, and that probably won't last very long. You smooth it off. Now, you keep him in retainers, and these teeth will come down and occlude together. You put some type of tension. I never run a wire under there. You do not need clasp on these upper retainers or lower ones. Never do it. You can put the wire in there and put a little composite under it or something and snap them over if you want to fix them where they can't already take them out. Now that's in a good class one too. I'm not looking straight at it, but it'll come together better. And this model, I'm sorry, the didn't get it centered right, or whoever. I don't think I took the picture, but somebody did. But we have widened this out, and we've got the roots out good, and the kid is breathing through his mouth now. He is not tongue thrusting, and just is doing real well. Let me go. I think that now here's the lower arch, and we've finished this. We got space in here even, see, and this 12-year molar will come in, and I like to watch them till they all get in there, and then you do something with the wisdom teeth. If you've got room for a wisdom tooth and it comes in, you need to tilt it up. I can go in 4 or 5 years after you finish the case and tilt the wisdom teeth up easier than you can take them out. Just trim off a little of the tissue and bond something on the side and put a little spring on it and bond a wire to 3 or 4 teeth, and you take this thing and raise this spring up and hook it, and it'll take that wisdom tooth or second molar and set it up beautifully well without putting braces on the rest of the teeth. Okay, that is the end of it, and I'm going to go back and we'll look at the facial structure here. Now that's, to me, is fine, and that I don't have to take an x-ray of that to see that that's good, and that's going to develop good, and it'll stay there. So I'm going to hush up, and we've used several things in this video to come out to do an interceptive preventive thing, and we're going to stay with it till this 12-year molars are in, and I like to see him until the wisdom teeth, something's done with them, and so I'll let you go. So doing orthodontics is not a 2-year, an 18 month, or a 10 month, or whatever you want to call it. It's a commitment to watching these for years. When you take on these cases, you want them to leave there good when they're grown, and keep them in whatever retention is necessary. So I'll sign off here, and hope that some of you enjoy that. So I've enjoyed giving it to you and everything. So we'll stop. Bye-bye.